So look, the therapeutic goals, what is it that the clinicians are trying to achieve in the first 3, 4, 5, 6 hours? The key one really is to minimise the infarct progressing. We can't do very much about the infarct that's taken place, but what we can try and do is stop the infarct expanding. And we can achieve that by some form of reperfusion therapy. You've heard about IVTPA, and I will talk a bit about mechanical embolectomy, and one of my colleagues is going to be giving a little talk on that shortly after. And the other key point is in trying to achieve that, we're attempting not to increase the hemorrhagic risk in the area that is already infarcted. And we call that futile recanalization. So reopening a vessel into an area of dead tissue doesn't help the dead tissue, but increases hemorrhage risk. And one of the other things that is obviously key in that point about hemorrhage is managing blood pressure appropriately, which luckily doesn't fall to us. Outcomes in stroke. Tony gave a very nice overview of, I would say, his view on stroke management and where it's going. I think those of us on the imaging side have a slightly different take on things, and I think that's healthy. But I will give you my perspective on where things are currently with neuroradiology across the world. And this starts really here. So while these are old references, certainly one or two of these facts are unchanged. Some of the newer data that was published last month in AJNR has probably supported that. We know that outcomes in acute stroke are poorer with large core infarcts. I will talk to you about what core means. But we know that is, whereas we used to describe it as less than a third of an MCA territory, we now quantify that with about 70 to 100 mils of dead tissue. We also know that severe initial strokes, i.e. those with an NIH of greater than 10, do badly. Yes, Tony will tell you that IST3 shows you that some bad strokes will do better, but it really is the minority. That is still yet to be disproven. We also know that patients with proximal vessel occlusions, and by that I mean occlusions of the middle cerebral artery, the distal ICA, and vertebral basilar artery, will also do badly. And in fact, 2/3 of major strokes, so 2/3 of patients with an NIH of greater than 10 will have a major vessel occlusion. And of those, the vast majority are the anterior circulation, so about 70% are in the M1. The M1 is the first part of the middle cerebral artery, as you know. The proximal M2 is really, I'm talking about the bifurcation, and then the ICA. So up to 90% of those will be anterior circulation strokes. So the evidence behind that really stems from the NINS and ECAS3 studies. And some of this you'll have seen, I'm sure, through the morning. But just to highlight a couple of the key features, the NINS study, which is the landmark study in 1995, demonstrated there was a 30% increase in good functional outcome with IVTPA up to 3 hours. But it was based on having an infarct of less than 1/3 of an MCA territory, and obviously no hemorrhage. And also, in this particular case, patients less than 80 years. Now we know that IST3 seems to have dealt reasonably adequately with the age issue. But for now, we're still dealing with 1/3 of an MCA territory. ECAS3 showed that it was probably beneficial up to 4.5 hours. Now this was a European study, and needless to say, the Americans don't really believe this. Because if you look, the severity of strokes in ECAS3 was significantly less severe than in NINS, and they think that we were, in Europe, thrombolizing TIAs. We'll never know, of course. The next thing to say about both of these landmark studies is that there's no information on vessel occlusions. So even though there are some substantial strokes in there, we have no idea what proportion of vessels were occluded, what proportion were major vessel occlusions and strokes. We have no idea whether they recanalized because we don't know whether they were occluded in the first place. That has subsequently changed with some of the newer studies. So that's the background. So what do I mean by core infarct? Well, this model is based on animal models, it's been validated with PET, and it is pretty much accepted in the world literature now on stroke imaging that such a model exists in humans. The nuances of it, of course, are not going to be the same as the rat, but I think we've got about as close to it as we can. By the core, I mean an irreversible area of dead tissue and tissue that is critically ischemic, that is unlikely to reperfuse regardless of what you try and do. Hypoperfused tissue, but that is salvageable, is known as the penumbra. And this is an important relationship, which a number of investigators have tried to explore. And I'll mention a little bit about that. So what are the goals of imaging? Well, the first is to exclude hemorrhage. We know that. The second is to exclude a mimic. And in our trust, so in Imperial HASU, we have about 1,500 patients every year, of which about 28% are not strokes. And if people tell you to put a scanner in A&E and scan everybody that comes through the door, that is not going to work, because your mimic rate will rocket. You do have to have some form of clinical, experienced stroke clinical management at the front door to try and sift out the ones that are obviously not strokes. The next thing to do is identify the core. This is absolutely essential, regardless of whether you're just giving IV treatment or whether you're considering mechanical IA intervention. And the next thing, if you can, is identify major vessel occlusion. If, in an ideal world, and there is, and I'll mention this a little bit later, we would like to know, and we're certainly trying to explore, whether there is a relationship between the dead tissue and the salvageable tissue. I'll come to that again. So, this we know, this is established. So, imaging the core, i.e., again, what is the area of dead tissue? We know that we need to be less than a third of an MCA territory, or 70 to 100 mils, if you can calculate that. For the purposes of the DGH setting, we're looking at a third of an MCA territory. So these are the techniques that we use, like NECT, non-enhanced CT, CTA source data, CBV map, CBF, MR, DWI, and if you're really lucky, an 11 flumazenil PET. And these increase with sensitivity and accuracy as you go down this scale. What we want to do is position ourselves somewhere where we can achieve it and get the best information. This clearly is out of the question. In the UK, I think we're going to struggle here. Imperial is one of the only centres that offers a 24/7 MRI service, and even we're struggling. I think we need to be here. This, for reasons I'll explain now, is going to be quite difficult to base a 21st century stroke service just on plain CT. I know this is not what you want to hear, but I'll try and explain why. So the evidence for plain CT, as I mentioned, was based on the NINS and ECAS3 studies. We know that the low density, if you can see it on a plain CT, is going to be the core infarct. Almost never does the low density on a plain CT reverse in a conventional ischemia scenario. In subarachnoid node hemorrhage and vasospasm and a bit of ischemia related to that, it's a different matter, that can sometimes reverse. But in conventional embolic or thromboembolic disease, it won't reverse for all intents and purposes. But we also know that the sensitivity of plain CT up to 3 hours is very poor. And in fact, the earlier you get, you're looking at 30% sensitivity. We also know that trying to reliably assess the size, which is crucial here, is also very difficult. The size, in terms of reliability, has improved a little bit with Aspects. And Aspects came out in Canada, it's the Alberta stroke score. It came out a long time ago. It's been validated as a reasonably reliable and reproducible technique. So if you're going to stick with CT, you have to use Aspects. On the whole, though, the plain CT is probably adequate for patients who are comfortably within the 3-hour timeline and who have an essentially normal or near normal looking CT. Because even if you imagine on a near normal looking CT and you look at the DWI, the chances of the DWI, if you were to have one, the chances of the MRI DWI being substantially worse than a completely normal CT, such that it would be not wise to give IV thrombolysis, is very unlikely. So in a near normal CT, we're pretty much okay for IV thrombolysis up to 3 hours. Tony will tell you it's fine up to 4.5 hours. I think most stroke physicians who work at Imperial and I think UCH will probably doubt that. Oops. You know, I hate these things. Okay, so that's the Alberta score. Just to refresh your memory, when you're looking at a plain CT, we're only looking at 2 slices. This is the classic slice of basal ganglia, third ventricle, frontal horns. So that's your lentiform nucleus, thalamus, internal capsule, and caudate head. You'll all be familiar with that slice. So that's the first slice you need to look at. The next one is through the bodies of the lateral ventricles. And what we do is we start off with a score of 10, and we deduct 1 for every area that's involved. And you have 4 deep areas, so the insula, the lentiform, the internal capsule, and the caudate, and 6 reasonably arbitrary cortical areas. And that line here, dividing M2 from M3, is essentially the central sulcus, and the same again, so M5 from M6 is central sulcus. So once you have allocated your areas, you then deduct for any area that's involved, and you end up with a score. If you have a score of less than 7, that is more than a third of an MCA territory. So just to, again, just things that you will be very comfortable with already. Plain CT, you're looking for areas of subtle grey-white matter differentiation loss, areas that, but typically talking about the middle cerebral artery, where it's really 7 out of 10 cases where that's what the territory will be. And so we're looking for loss of the insular ribbon, we're looking for subtle areas of low attenuation, and in some cases, some sulcal swelling. Obviously, the sulcal swelling will be more substantial the larger the area. I don't want to spend too long on this, but just to emphasize that the window you should be using is a 35-35 window. So look at your brain scan on a normal window, but then for subtle strokes, you're going to be seeing that on a 35-35, and you can see there's a big difference in, big in inverted commas, difference between that slice and that slice, and the sensitivity of the stroke. Similarly, you need to look, it's quite difficult on a normal window, but you can just see normal insula here, and you've got the loss of the insula there, and subtle area of low density that causes loss of the grey-white matter pattern. And also you have, in this particular case, a dot in the M2 in the silken fissure. Just to remind you that you will see this more and more as you do more acute strokes. We see it in about 6 out of 10 cases that involve the middle cerebral artery. So, by the way, just to re-emphasize, that's the thrombus. When the stroke gets quite large, you might think it'd be easier to see. It can actually be quite difficult. This was a case from a year ago or so where it wasn't quite appreciated that the whole of this territory is involved. Even when you look on the stroke window, you can make out there's a difference in the lentiform nucleus very clearly. But when the whole of the area on a normal window is involved, it becomes quite difficult. What I'm telling you is obviously clear, and that patient obviously progressed on to what you're familiar with seeing. So CT, as I say, adequate up to 3 hours if it looks completely normal for giving thrombolysis. I think we need to explore some of the other options. To get source data, we call this the source images. To get the source images of a CTA, you obviously have to have done the CTA. It needs to be performed prior to the perfusion scan if you're going to do it. We'll talk about that in a minute. You need to have a saline chase. The problem with anybody that has a number of detectors over 64 is that, in fact, they become less reliable. What we're looking for by a process of complex mathematics, which I don't have the faintest idea about, you need to have a steady state of concentration of contrast, and that can be delivered by a tight bolus with a saline chase, and the scanner mustn't be too fast. So as you upgrade your scanners, this is going to be more and more difficult. So we don't use this. We used to, we don't use it anymore. So we try and achieve the core by using cerebral blood volume, which we do a CT perfusion scan on. And the details of this I forward to you. I'm sure some of you will have seen it. Last year I gave a talk on the technique of giving a CBV, but I think in terms of the actual technique, I think it's going to be of less interest to you. So just the highlights really. We know that when you generate a CTP series of maps, the cerebral blood volume correlates best with DWI. So we know that DWI is the closest marker of the core infarct there is, other than PET, and CBV correlates best with DWI. However, just in the last 2 months, the group in Boston have demonstrated that in fact the CBF, its thresholded appropriately, will actually be more accurate. The difficulty is here is that depending on which platform of processing, post-processing you use, and even which scanner vendor you have, the reliability of thresholding is crazy. Now, what I mean by thresholding is when you have your cerebral blood flow map, you can set the threshold to less than 18 to 20 milligrams of blood, and the map will highlight how much tissue is below that level, and that is effectively your core. It's all automated. The problem is, as I say, that different post-processing platforms make that a little unreliable. So we haven't shifted to this yet. We're going to stick with CBV. Remember, though, that in both that, doing the CTA, and that, we're talking about another imaging technique, which means more complex imaging for you. It also means a time delay for the patient. So I will tell you what we do when we go through towards the end, but we don't delay intravenous therapy where possible. Well, there is no doubt that it would be ideal to perform an MR study. in terms of the core. We know that as many as 90% of patients, probably more than 90% of patients, have lesions on DWI that do not reverse. You may have seen in the literature over the last couple of years that, not all lesions with DWI are irreversible. In fact, yes, that's true, about 10% do reverse, up to 10%, but it's the vanishing minority when it comes to the acute stroke scenario. So it's still the gold standard in terms of imaging. But again, same issues. How many patients get a scanner? Who has access, more importantly? Cost of having an MR, cost of interpreting it, the duration in there, the time, but also safety and tolerability. These are all issues that we're struggling with, and we're currently doing a workflow assessment to see if we can, having funded it, to see if we can actually use it in a practical way. So that's the core. Core is essential. You need to know how much of the tissue is dead. You do it with plain CT. Ideally, you should do it with cerebral blood volume. And if you're really lucky, you do it with MR. The UK is years away from doing it with MR, I think. The next thing to do, because we know that vessel occlusions change outcomes, is to try and establish whether there is a vessel occlusion. There's only any point doing this if you can transfer your patient to an interventional unit where they can take the clot out. Now, this is all predicated on our belief as radiologists, neurointerventionists, and neuroradiologists that removing the clot will help the patient. Now, as Tony will have said to you, he thinks the UK is 10 years away from there. We may be, but if we don't equip ourselves, then we will be bringing up the rear in terms of where the UK should be. The US is charging ahead with this. Now, their funding system is different. They have different mechanics. But we are going to be left behind in terms of gearing up to provide a service if we don't start preparing ourselves now. So whilst he's quite right, NHS London can't afford, for example, I know you're not all from London, but for example, I know NHS London can't afford to equip us all with 6 interventionalists in each unit. That's not going to work. But at the same time, we do have to start coming together and thinking how we're going to do it. And at Imperial, we're trying on the service of 3 neurointerventionists who are going above and beyond the call of duty to try and get it going. Don't delay again. If we're going to look for the vessel, you need to have a relationship with your interventional unit and be prepared, and they need to be prepared for it. CTA is more reliable. Yes, MRA is quicker to interpret. It's just, again, we're looking at the same issues with MR. And we need to know, and the other benefit of this is that your interventionist will know if there's a problem with the carotids or the problem with the arch, because you're doing an arch study. But as Tony quite rightly pointed out, the evidence for thrombectomy is weak. It's really, you'll see from here, this is the IV thrombolysis study, which was a randomized control study. These are all the major device studies, which you will see there are no randomized controlled trials at all. PROACT 2, which I've not put up here, was an intra-arterial thrombolysis study. That did show some benefit, was a randomized study of only about 190 patients, and showed very minimal benefit. But when you look at the recanalization rates, for example, of Penumbra, and now there's a newer device called Solitaire, we're looking at being able to open up the vessel in over 4/5 of cases, which is tremendous. And it really, the reason why we're not delivering benefit here, this is the modified Rankin score. So as Tony explained, a modified Rankin score of less than 2 is either independent or only with minor disability. So this was the NIN study. I showed you 39% compared with control, so an improvement there. But these are all relatively poor, and in fact you'll see not as good as NINs. But we know that the reasons for these are probably because of the time it takes to get the patient on the unit, get an anaesthetist, get the device ready. And we're really talking about the time it takes to get these vessels open. So we must not give up hope on here, and this is what we should be aiming for. CTA, you will have seen these. Nothing difficult about an acute stroke CTA. It is a rapid assessment of the vessels. We're not looking for bits of stenosis here and a bit of calcium here and there. You want to know, is there a vessel cut-off in the ICA, the middle cerebral artery, or the vascular artery? That's it for the purposes of an acute study. This was just up here to remind you to forget about your 3D volume rendered studies. They're a waste of time. Nice to show in a meeting, but even then, not great. There's no place for these in acute stroke imaging. It takes too long and don't really show you very much. Just because I've done it, there's the cut-off. As you can see better on here. And I'll show you lots more cases. 3D, if you're going to do MRA, do a 3D time of flight. If you want the arch up, you'll need to do a contrast-enhanced MRA. They are quick, and you can make them independent of radiographers in the sense that you don't have to make sure that they get the bolus timed rightly. You can do a time resolve study so that they capture it on multiple occasions, so you will have got the best study somewhere in that sequence. They are quick to interpret, but you have to do the whole shebang of getting them on the scanner and making sure they're safe. I don't think there's time for that. So we've looked at the core, we've looked at the vascular imaging. There's a whole lot of images coming. What we're trying to do now is trying to get the penumbra as well. So you'll remember that is the bit that is ischemic but salvageable. Why? Well, there's not an awful lot of evidence to support that it's going to make a difference. There are a couple of studies. There's the EPIC study and the DIAS-2 study, both of which didn't really show any benefit, but they were small recruitment studies. In fact, one of them was an MR study, barely recruited more than 150 patients. And slow take-up. And we really think that most of those were very mild strokes. And what the beauty of the penumbra, we think the beauty of the penumbra technique is in the more severe strokes. We think that if you have, we're pretty confident about this, is that if you have an infarct with a small core, so small amount of dead tissue, and no penumbra, so no salvageable tissue, there is no point giving them treatment, because there is nothing to save. Equally, we think that if there is a large area of ischemic tissue and only a small core, it still has to be a small core, otherwise you can't treat them, but if there's a small core, we call these mismatched, they're likely to be the ones that benefit the most. In patients with vessel occlusions, if you imagine you have a middle cerebral artery occlusion, which again, as I say, is about 60% of all major strokes, it's not a small number, and if they have a small core, because of the occlusion, they are likely to have a large area of ischemic tissue. So you could argue, and the Americans argue, there's no point imaging for the penumbra here. I'll tell you what the penumbra is in a minute. There's no point imaging for the penumbra here. We do, because we're not as confident as they are, and we're getting the data anyway. What I mean by that is, when we generate our CBV maps from the perfusion study, we're getting the CBF and the MTT maps anyway. This is cerebral blood flow and the mean transit time. And those maps are equivalent to the penumbra. So where the reduced cerebral blood flow or prolonged mean transit time, that is ischemic tissue that isn't dead already. So let's go into some examples in a second. This is our protocol. It's quite complicated, and the clinicians are now used to it. We have, because we offer a thrombectomy service, it is more complicated. So patients who are eligible for TPA have no hemorrhage and no large infarct on the plain CT, but in whom the NIH is less than 8, we don't do any advanced imaging, they go straight to intravenous thrombolysis. Between 3 and 4.5 hours, because we're not so sure about this safety of 4.5 hours from ECAS-3, we do some advanced imaging. We do CTA and we do CT perfusion to look at the relationship of the dead tissue versus the ischemic. If the NIH is greater than 8, because we know that a large majority of those patients will have a vessel occlusion, or if there's a dense vessel on the CT, we give the intravenous TPA first, then we get them back on the table and do a CTA and CTP. If it's between 4.5 to 6 hours, we do that first. And if the vessel's occluded, they go straight to thrombectomy, regardless of whether they've had their IV TPA. Sometimes we may wait to see if there's no improvement on the IV. Patients who come to hospital with wake-ups, this is a big issue. There's a study in the States and in Holland that's called Wake Up. That is going to be looking at the impact of MRI and CT perfusion on patients who present to hospital having woken up with a stroke. It's not a small problem, and it means that in most units you automatically discount them because you don't have their time of onset. But it may very well have been that they just had their stroke 20 minutes before they woke up. But because you don't know, you discount them. So there's a study looking at this, and we're treating all our wake-ups with MR, or not treating them, but we're investigating them with MRI. So they get a DWI, perfusion, susceptibility, contrast-enhanced MRA. Now that looks like a lot, but it takes 11.5 minutes. But it takes 20 minutes to get them on and off. And if they can't go in the MR because either they won't tolerate it or you don't have enough information on MR safety, then, for example, if they're dysphasic and unaccompanied, then they get a CTA CTP. So, case 1. These are 4 examples of I've tried to show you how the advanced imaging has changed our decision. So, patient presented with an NIH SS of 19, following a coronary angiogram at around 3.5 hours. They presented, the IV TPA was administered. And then we did CTA CTP, and then we'll show you the images there. They didn't improve. and they went on to thrombectomy. So this is the plain CT. You'll see that there is a dense vessel on the right MCA. So we know that they've got a dense vessel. We know that we want to get them back in there for a CTA, but there's not a huge amount going on the plain CT. This is the normal window, this is the stroke window. And you'll see this is the normal left lentiform. Can you see that that's greyed out here? Very subtle, but a small core. We know that's a small core, so we're quite happy for them to have an intravenous thrombolysis, but we know they've got a vessel occlusion. So what they really need, in our view, is a thrombectomy, and in most views of most neurointerventional units. So they have their intravenous thrombolysis, as I said on the first slide. They didn't improve, but in the meantime, while they're having their intravenous, so they've had their bolus, the infusion is dripping in, they do CT perfusion. So that is the CBV. So the CBV, remember, is the core. So this is telling you what is dead tissue. So if we look through these, we'll see that other than what we saw on the CT, which was hard to see, I grant you, but very easy to see here. So there's posterior aspect of lentiform nucleus, and that's dead tissue. But look at the mean transit time. The whole of the territory is ischemic. We know that that is likely to be the case. With a major vessel occlusion and a small core, we know that the whole of this territory, but it is nice and it is reassuring, particularly if you've got juniors looking at the scan, for them to see this. We would have got this map anyway, but we automatically produce this, so there's no added impact to us to get the additional information. Sure enough, on the CTA done at the same time, by the way, all of that imaging takes about 3 minutes. So there's the ICA coming up, A1, so that's the anterior cerebral artery, stump of middle cerebral artery, so that's the occlusion. So we know that they've got that. That was what it looked like on angiography, and this was post-embolization, embolectomy. And the NIH improved from 19 to 9. So there is a reason to do this. Second case, presented at 2.5 hours with the NEC, so this is the non-enhanced aspect score of about 7. They're eligible for TPA because only a third of the territory is involved. Remember, you start with 10, you deduct an area, a point for every area that's involved. So that's just about satisfactory. So they could have had TPA, but we elected to do CBV. There was something unusual about the patient in terms of the clinical, so the clinicians and neurologists asked us to do a CTA, CTP. So here we now see there was a dense vessel. I think our suspicion was that this was likely to be bigger than what we were seeing. The time wasn't quite right. You can see here that there is loss of the insula. There's a little bit of loss of the frontal operculum, but not an awful lot. So on here, 3 points, so an aspect of 7, but on the cerebral blood volume, substantially bigger. So this is dead tissue. And you can see there's much more involved here than there was evident on the CT. So we felt that there was not enough, or rather there was too much of dead tissue on here to justify intravenous thrombolysis. So whereas we would have done it on the plain CT, we decided not to do it because in fact there was too much dead tissue. What difference would it have made? Well, we don't, unfortunately. Case 3 was uncertain diagnosis. Somebody presented with expressive dysphasia and very little else. The onset was unclear, but we think it was in excess of 4.5 hours. So on the basis of that, not for TPA. So the plain CT, not very much, a lot of background small vessel disease, bit of volume loss. Looking for expressive dysphasia, looking at the frontal operculum, nothing really at all to hang your hat on there, even with changing the windows. When you look at the CT perfusion, again, just keep your eye on this map first. This is the cerebral volume, so this would be dead tissue. So there's nothing here. But if you look at the mean transit time and the blood flow, this is, first of all, remember this was an uncertain diagnosis of expressive dysphasia, so we know now this is ischemic. So there is ischemic tissue in the middle cerebral artery territory, right where you would expect dysphasia. And it's corroborated by the cerebral blood flow. So rather than not treating this patient, because there was no core, there is virtually no risk to giving IV thrombolysis, even though it was beyond 4.5 hours, so off license. So he was treated and made a full recovery. And this is the full CT later, so there's no infarct there. So that was another decision that we would have not made had we not had the advanced imaging. Case 4, patient was on, had atrial fibrillation on warfarin. The INR was 1.5, now 1.4, sorry. So that's sort of borderline for where our neurologists would want to treat if there was a stroke. but they were unwilling. Really, it's 1.3, so they're a little unwilling. The time is around 4 hours. So because they were unwilling, they wanted more information. So we look at the plain CT. There's unequivocal low density here, and probably, well, definitely some down here. The density of this suggests something that's perhaps older than they were wondering about. We did perfusion, and you can see that the cerebral blood volume and the cerebral blood flow essentially match. There's very little in it. So there is no extra tissue here that is salvageable that hasn't already died, which in fact backs up the fact that this was probably older than we thought. So where they were unwilling and we've given them a bit more information, they elected not to treat that patient. So what have we got with the advanced imaging? So these are where we are with it so far. We have treated that around 1,000 patients over the last couple of years. We're up to May 2012, that's where we are. We get, as I say, about 1,500 in, of which around 28, 29% are mimics. So these are non-selected, as Tony was saying, non-selected patients are eligible for treatment at the most basic of assessments. And we end up thrombolizing about 12% this year. When we started off, it was about 9, 10. So we're right up there in terms of London units. We do this many perfusion scans, approximately, so not very many so far. So it'll be around, I would guess, about 80 this year. We started a new protocol here. And we've changed management, we think, in about 1/3 of cases, which is not insignificant. Well, what's the future? Is there a role for MR? Yes, but we're looking at it in terms of the actual workflow. You need radiographers that are going to be available 24/7. It is not a small undertaking. We need to validate the benefits of what I've just been talking about. It is extremely difficult because recruitment is low, not many centres do it. That's the first problem. The second problem is that the post-processing and the platforms and the scanners, they're trying to get the data in one system where they can be compared is extremely difficult. We also need RCT, so randomized controlled trials, to look at the value of mechanical embolectomy. Because if mechanical embolectomy is indeed shown to be a waste of time, which I think is almost never going to happen, then there's no point doing CTA. So some of the imaging where I'm trying to show you today is blue skies stuff, but it is things that we need to be moving towards. Where we think that the penumbral imaging will be is in trying to be a bit more sophisticated in how we select the patients that are best suited for treatment, rather than this sort of global approach to patient comes within 3 hours, treat them all. That is not the way I think it's going to go forward. It's going to be, certainly in terms of the embolectomy, it will be which patients are best suited to it. Otherwise, you end up with trials that have been done already, or studies that have been done already with reasonably high complication rates and low benefits. So after excluding hemorrhage, the first thing to do is try and assess the size of the dead tissue. You can do that with plain CT by all means up to 3 hours, but remember that your sensitivity will be low. You will be missing a significant number of patients in terms of the size. If you can do perfusion, then try and do it. Do a cerebral blood volume. It's not difficult. It's all post-processed automatically. You can look at it. It's pretty quick to undertake. It's about a minute to do and about 5 minutes to post-process. But you will have, certainly in less than 3 hours, you will have some problems from your clinicians. Beyond 3 hours, you find it easier to get their support. We need to try and think about whether you're going to feed into an embolectomy unit, and if you are, then you need to be thinking about CTAs. And don't delay. Whatever you do, I'm advocating advanced techniques, and you will need a certain amount of logistical setup to make sure you don't delay your intravenous therapy. What we do is we get the therapy on board, and then we scan them. And I've said that penumbral imaging might be particularly useful in selecting patients for embolectomy, but also for wake-up strokes and for diagnoses that are uncertain. Thank you.